Bismillahirrahmanirrahim. So today is 22nd of July 2022. So this is the third lecture of critical congenital heart disease presenting in neonatal period. And initially we talk about how to approach newborn with suspected congenital heart disease. And we talk about duct-dependent systemic circulation and duct-dependent pulmonary circulation. And we talk about prostaglandin, how to start, when to start. We talk about the side effects of prostaglandin. And also then we talk about the post-operative, once patient comes to the ICU after operation, then what is a normal handover. Even before that, we talk about the genetic analysis and what extra things you need to do in a patient who has been diagnosed a congenital heart disease in the newborn. I talk about doing head ultrasound and ultrasound KUB and chromosomal analysis. Because we know that there is an association like the Joy syndrome, Down trisomies, including Down syndrome. And also, we talk about how to take handover for these patients in ICU once they come to the pediatric ICU after congenital heart surgery repair, and that is my area of expertise. And then also we talk about what is a normal convalescence. Normal convalescence means how these patients, they has been taken care by nurses and doctors in pediatric cardiac ICU after operation. All right. So now we spend couple of minutes. Again, the slide is the same. This is very important slide, and I think also it is part of FCPS curriculum that we need to understand that what's the difference between duct-dependent systemic circulation and duct-dependent pulmonary circulation, because you might get MCQs in your FCPS written exam. So I thought maybe I can go to the, yes. इसको बंद करें हम? No, 1 minute. Maybe we can do some, there is a way to do. We can continue, that's fine. Because I have to stop the recording. So what is the example of, what is the example of duct-dependent systemic circulation? Huh? Excellent, excellent. Excellent, again, excellent. Or, किसने कहा excellent, हाय बोला. So anything which is obstructing to the systemic cardiac output is your duct-dependent systemic circulation lesion we are talking about. So if in these, what we have just discussed now, critical aortic stenosis, critical coarctation, interrupted aortic arch, or hypoplastic left heart syndrome, believe me, this is part of FCPS curriculum. You will get a MCQ. And maybe if I have time, I can, for each scenario, I can tell you how they present in the neonatal age. Because normally they give you the scenario and then they give you the X-ray, ECG, or maybe not at your level, fellows level, they give you the cardiac cath also. All right? So we can discuss that one also. And what is the duct-dependent pulmonary circulation? One by one, because we are doing recording also. Maybe you can speak loud so that critical pulmonary stenosis. All right, critical pulmonary stenosis need that is a duct-dependent pulmonary lesion, pulmonary circulation, duct-dependent pulmonary circulation lesion. All right, because what does it mean? That if you have those kind of lesion, there will be flow obstructed to the pulmonary. I can make a little diagram so we can for the new people who are sitting here. So what happens? Normally, vale. So this is your pulmonary artery. This is aorta. This is pulmonary valve. I really concentrate on this picture always, because once you know the structure, once you know the normal, then it is easy to understand abnormal. So this is your LV, LA, RA, RV. This is pulmonary outflow tract. This is pulmonary artery. This is ductus arteriosus, this one. All right. And this is your arch of aorta. This is aorta is arising. Okay, so who will tell me what is this? Correct. Very good. Excellent. जिन्होंने पार्ट 1 किया अभी उनको बताना चाहिए. ठीक है. So what is the first branch of arch of aorta? Innominate artery. Innominate artery is the first branch that divides into the right subclavian and right common carotid. ठीक हो गया? Right subclavian, right common carotid. ठीक है? यहाँ तक ठीक है? Actually, we take the right subclavian and do the BT shunt. We put on the pulmonary artery. Later on we will talk sometime, but these things we need to know. All right. And what is this branch? Shabash. Excellent. Very. This is we call it normal arch of aorta, which is left-sided, and normal. It's a normal branch distribution. What the normal people have, because sometimes people they have right-sided aortic arch also. Then they might have a mirror imaging branching. All right. So this is a normal pattern. You have a ductus arteriosus. Now things are very clear for the people to understand what is the duct-dependent systemic circulation. So duct-dependent systemic circulation, just concentrate here what happens. So if you have, इसने उम्मे हबीबा ने बताया interrupted aortic arch. किसी बंदे ने बताया critical aortic stenosis. So you have obstruction here, or you have critical coarctation of aorta. I don't want to do here, but you have critical coarctation of aorta like this. ठीक है? वो देना है. Because we want to make sure everybody understand this point. So, or you may be having all hypoplastic structure on the left side, which is hypoplastic left heart syndrome. If you are more precisely, hypoplastic left heart syndrome has aortic and mitral atresia. All right, but all left-sided chambers embryologically they are not well developed, and that structure we call it. So what happens now? You see now, if you have problem here, all right, if you have a problem here, so your body is not perfused by the systemic flow. Just concentrate here. What you do, you give a prostaglandin to open this duct, and now the RV is pumping blood into the pulmonary trunk, and you perfuse body retrograde like this by opening the duct and patient we ventilate in the cardiac ICU till the surgeon take to the OR to fix the baby. And these all patients, they are newborn. And if you don't start prostaglandin, they die. All right. And unfortunately, we have an issue with the prostaglandin right now in Pakistan. So how important is prostaglandin here? So these are the babies, maybe they died before coming to you, in the community, in the emergency, where you cannot do even, because you need to do echo for these patients. But this is important to understand that, okay, now you concentrate what is duct dependent pulmonary circulation. So what happens, what are the lesions? We talk about critical PS. So again, you have obstruction here. Or what are the other possibilities? Huh? Tricuspid atresia, very good. Or truncus arteriosus has a different physiology. We will not talk here. Okay? You have pulmonary atresia also. Think about only right-sided structures now. Okay? So you may have pulmonary atresia or you may have tricuspid atresia. Tricuspid valve is the one which is here. So this is what happens now. Now the lungs, they are not getting blood. So what happens in the womb? Obviously, the LV is pumping blood, and now baby is getting. Obviously, there is not much flow to the lungs in the womb. Only maybe like 10%, because pulmonary circulation is not active at that time. Lungs, obviously, they are developing phase. So what happens once a baby is out? Baby need to breathe. Duct is already open. Lungs get expanded and duct is open. But duct has to close. Now I am giving one statement. Duct has to close physiologically within 72 hours and structurally within 1 week. All right. So this is what happens. So now baby is 48 hours and baby try to become cyanotic. And sometimes, they just present like shock, because as I told you in the previous lecture also, if there is no pulmonary blood flow, no blood flow to the left side of the heart, because there is no preload to the left side of the heart. Remember we talked about in the last lecture. So the same happens in the pulmonary hypertension also. So now you don't have blood which LV used to give to the systemic circulation. So again you have a shock condition, but they predominantly initially they present with hypoxemia, hypoxic, and then if they don't have intracardiac communication, they present like shock. So this is what happens now. So in these patients, you give prostaglandin, you open the duct and you perfuse the lungs. So duct dependent pulmonary circulation, we have critical PS, pulmonary atresia and tricuspid atresia. And believe me, tricuspid atresia or pulmonary atresia you will get in the MCQ. This is must MCQ in your FCPS exam. Obviously, they might give you the tricuspid atresia in a newborn. They give you the ECG, all right, because they have a left axis deviation in tricuspid atresia, and that is the catch point. And then pulmonary atresia, they can give you like with hypoxemia, or they can give you transposition of great arteries. They might show you the agon side appearance on the X-ray, truncus arteriosus, or you might get the TAPVR like figure of 8. So these are all MCQs for your FCPS part 2. So now we discuss in detail about this thing is clear, because with the diagram. So we have duct dependent, systemic, and now detransposition of the great arteries. Also there is a D mean dextro, and they might have the LIGO like L, all right, but we call it also congenital corrected transposition of great arteries. But here there is a, arteries, they are arising not from respective ventricles. And this patient you might get in your MCQs by like, it's like 48 hours, 72 hours baby who is hypoxic. and they might give you the X-ray egg on site. And again, maybe MCQ is to start prostaglandin, and they might give you different. Because these patients, you start prostaglandin, hypoxia improves, you bring them to the ICU, and normally these cardiac patients, they don't go to the neonatal ICU. We transfer them to the pediatric ICU or pediatric cardiac. All over the world, this is the scenario. Even in England, in South Africa, in Australia, in America, every congenital heart disease come to the pediatric ICU to fix. So that is the reason we see these patients in pediatric ICU. Because neonatal fellows, they transfer. And neonatal fellows, they come for their rotation for 2 months in pediatric ICU. So once you bring the patient, we give them like prostaglandin, we optimize their electrolytes, we do the basic thing what I just told you, ultrasound head, ultrasound KUV, we document the urine output, calcium, metabolic workup, genetic analysis, and then obviously you talk to the parents, disclose, sit with them, take consent, and you take to the baby to the cath lab to do the septostomy, Rashkin procedure. All right, septostomy, atrial septostomy you do. So what you do normally, you go and you inflate the balloon and you make the ASD bigger, so that there will be free communication till the patient is fixed surgically. And ultimate, you have to fix before 8 weeks of life. That you can read why we need to fix before 6 to 8 weeks of life. But ultimate you have to fix by doing, and that is the prototype procedure we get in the pediatric cardiac ICU, arterial switch, Gittini procedure. So patient come to you, and then, I mean, that's a lot of physiology, but you need to know in patient में detransposition में you do arterial switch operation, and patient, they might have a normal life expectancy like 40 to 50 years. So initially they get atrial septostomy, then you bring the baby another admission, maybe like before normally, even we do at 7 days of life. Immediately they fix in developed countries. But you have to do before 6 to 8 weeks of life, before the LV start to regress. We'll talk sometime why the LV start to regress. So total anomalous pulmonary venous drainage, they have partial and they have total pulmonary venous, total they have 3 types we discussed before. They have supracardiac, also FCPS need to know that one. There are 3 types, supracardiac, cardiac, and then the infracardiac. Infracardiac, remember we talk about the obstructed infracardiac, which they present like RDS on the X-ray. And supracardiac and cardiac, they present like ASD. But they present like increased pulmonary blood flow. So these are the congenital cyanotic heart disease who present with not with decreased pulmonary blood flow, they present with increased pulmonary blood flow. And if you talk about partial, they just behave like ASD. And even sometimes you don't know, you diagnose them like at 2 or 3 year old. Once they present with a recurrent respiratory infection, you do echo, and then you came to know this is a partial anomalous pulmonary venous drainage. But why I put total partial, remember they present later, because we are talking about neonatal congenital heart disease. So total anomalous pulmonary venous drainage, and in a supracardiac you get figure of 8 appearance. You can read what is figure of 8. That is written in Nelson also. So these are the diseases which they can present in the neonatal age. This is just a diagrammatic, depiction of what happens in hypoplastic left heart syndrome. You see there are structures as I told you, what valve is this one? Yes. And so you see here, this is the hypoplastic left ventricle, and you see how small is the aortic ascending aorta, because there is no blood flow embryologically and there is less development in the womb. So all left-sided structures, they are hypoplastic. So this patient needs, what we need? Prostaglandin. And then you later on, obviously these patients, they stay in the ICU for 3-4 months. We'll talk a little bit about, because this is one of the prototypes. We get patients in the pediatric cardiac ICU, and they are newborns. All they are newborns. This is single ventricle physiology, maybe out of your scope, but just you need to know what happens. So you see all structures, they are small. There is a large PDA, hypoplastic aortic aorta, and hypoplastic mitral and aortic valve. You can just see the structures. So what is the pathology? Aortic atresia, severe stenosis, and all left-sided structures, they are hypoplastic. 1.5% of congenital heart defect. What is the most common congenital heart defect? But this is for pediatric. Most common congenital heart problem in adult is ASD. And most common congenital heart anomaly is bicuspid aortic valve, even more than VSD and ASD, bicuspid aortic valve. Normal population also they have. So duct dependent for systemic blood flow at birth, we talk about what is duct dependency in patient may have associated chromosomal or developmental abnormalities. So may be diagnosed by fetal. 50 to 60% of hypoplastic left heart syndrome patient in America, they diagnosed by fetal echo. And also there is a concept of in utero transfer. So what is in utero transfer? You ask mother to get to the delivered in a hospital where there is a tertiary care congenital heart disease surgery going on. Because not every hospital in America also offer you the congenital heart disease surgery in the neonatal age. So you bring the patient from other city to the main like Philadelphia, and then she deliver in that hospital, and immediately then you take baby because you already know that she has a baby with the hypoplastic left heart syndrome. I mean, there is a lot of discussion about genetic counseling. You talk to the mother whether she want to opt that baby or not. But once he said the family agreed that we want to go ahead, you talk to them that what is their life expectancy with single ventricle in a hypoplastic. So depend also, this is for you. Single ventricle depend on, you have a single ventricle like pulmonary atresia or you have hypoplastic left heart syndrome. So what is your systemic ventricle? In hypoplastic left heart syndrome, your systemic ventricle is RV basically. So RV patient can live 30 years with maximum management. But if you have a systemic ventricle, the best single ventricle, they have a double inlet left ventricle. That is a little complex. But if the patient has single ventricle pathology with the right-sided problem like pulmonary atresia, then you have a better longevity, like 40 years. Because still your systemic ventricle is LV in case of pulmonary atresia. Anyway, you diagnose on fetal ultrasound and prognostic issue. I mean, there is a lot of debate, but clinical presentation you need to know. As a FCPS student, they present like with shock, cardiogenic shock. At after birth, maybe like 48 hours, and poor perfusion, decreased pulse. And what are the signs of shock we discussed? Decrease urine output, increase lactate, and decrease mixed venous saturation. Or obviously, clinically, you have tachycardia, you have hypotension, your perfusion is poor, your capillary refill time is prolonged, your urine output is less, and your peripheries are cold. In spite, you have a hyperthermia in the center. I mean, if you put any patient with a shock, rectal temperature in the anus, they are hyperthermic, 39 temperature. Because this is what happens, then you have a temperature gap between core and peripheral. Because we take core temperature from anus. So 39 temperature and periphery is 34. So you have a 5 of gap. That is shock. Normally gap how much? Up to 2 acceptable for us. But if you have more than 2, you have a problem. All right? So clinically, they present like a shock, profound metabolic acidosis, and they may or they may not have a murmur. Echocardiogram, obviously you do echo, X-ray, and then you ask for echo, and then you come to know, oh, this patient has hypoplastic left heart syndrome, and maybe already you are ventilating that patient, then you start prostaglandin. What are the side effects of prostaglandin? We talk about hypotension, apnea. Baby can flush, all right. Hypotension is very common with, especially with the high dose. So prostaglandin E1, you start with 0.05 to 0.1 microgram per kg per minute. Watch for side effect. And I mean, also there is concept. Remember, these single ventricle patients, you don't need to give them oxygen. It will take some time to tell you, but these are the patients where you don't give them oxygen. because if you give them oxygen, there is a steal phenomena, absolutely, and then you have a decreased urine output, metabolic acidosis. Because so if I explain you just for your simplicity, so what happened in single ventricle? This is, I always make this diagram. This is your any ventricle, LV or RV, depending on what problem you have. So you have single vessel arising from the heart, which is supplying both to the lungs and the system. So you have here SVR, Dr. Dev, this is for you, and this is SVR, this is PVR. So remember, SVR is 5 times more than the PVR. So concentrate here, all cardiology is like physics. पाइप को देखा, पाइप पानी वहां जाएगा, जो पाइप बड़ा होगा और जिसके एंड पे रेजिस्टेंस कम होगी. So now concentrate here, what happens now? So in these, if this pipe has a blood, where it tends to go more? Yes, that is lungs. So if, okay, now I wish you could understand that physiology in single ventricle. So if more blood goes to the lungs, what will happen? Saturation will be better. Normally in cyanotic heart disease, saturation 70, 80. But if you saturate 90, we don't want that one. We want patient to saturate like 80. Why? Because if you saturation like 80, then almost equal blood is going towards the system also. This is your systemic circulation. This is your kidney. This is your lactate cleaning system. So this is your systemic circulation. So if you have 90 saturation, blood will go less more here, and that you can calculate by QP-QS ratio. So we want QP-QS ratio of 1:1, equal blood. Saturation 75 is better, even better than 80 for me. I keep the saturation 75. And then you can calculate exactly by formulas that they have equal system and pulmonary blood flow. This is system, systemic blood flow, this is pulmonary. So remember now, what happens now? What does oxygen do? Oxygen drops the PVR. We understand, huh? Oxygen drops the pulmonary vascular resistance. We know that one. So if you give them more oxygen, this PVR will drop more. This saturation will go from 90 to 100. So there will be more steal from the system. Because you have only one artery here, which is supplying both. So if you are going more blood, less is going here. So what will happen? Your lactate will build up, your urine output will drop, and your renal failure will occur. Alright, so that is the reason if you keep saturation 75, then equal blood is going there, your lactate will start clearing, your metabolic acidosis start improving, your mixed venous saturation is around 70%, and you have a normal circulation. So this is what our job in ICU before they fix that patient in the cardiac OT. And then they bring again and we do the same rehearsal. And just for your knowledge, 70% of patients in America where I work, it was a hypoplastic left heart syndrome after Norwood procedure. I mean, there is a lot of work going on, and these patients, they go home. I mean, because, parents, they don't opt for that, their patient leave to die. So they opt for, okay, go ahead, doctor, and fix it. A lot of times, parents also, they opt for that, don't do anything, because they feel that doing more is harm to the patient. So it depends on how the patient, want to go. Anyway, so this is the physiology. So we keep saturation and we keep PO2 around like 40. I think this picture gives you the clear idea why in single ventricle pathology we don't want to keep higher saturation. Because and this happens same with if someone has like premature baby in the NICU has a big ductus. So I walk to the bedside and I turn their FiO2 down, because if the big ductus in premature baby, I don't want saturation, on the higher side. I want lower, because then you can dry the lung and you can extubate the baby. I mean, there is a lot of maneuvers we can do other than, the endomethacin. Because medically, like ibuprofen, paracetamol, these ducts you are not closing. You have to give endomethacin or other. or you have to surgically ligate. So, and also you can give them inhaled CO2 to manipulate pulmonary vascular resistance. What happens to the CO2? So if you give them CO2, you increase the CO2 and you are increasing the PVR. And once you increase the PVR, your circuit can be balanced. This is very rare, but I have never used actually CO2. Normally if you put them on 21%, and even sometimes I have given them on ventilator 18%. I mean, there is a way to give that one, but they start to improve. But then there is a lot of other things also. We have vasodilator also. So sometimes we give them, like other than milrinone, we put them on some vasodilators, and then you bring the SVR down. Once you bring the SVR down, the blood is more towards the system. So what we are trying to achieve? We are trying to achieve QP/QS ratio balance. Also, like person might ask you VSD closure indication. So you have to tell them if the QP/QS ratio is more than 3 and patient is failing to medical management, that's a surgical indication, because someone can ask you in the long case if there is VSD with a like endocarditis patient. Anyway, we now skip these slides. This is for the fellow. And another one, this is for you. This is coarctation of aorta. So we talk about that this is what, duct-dependent pulmonary or systemic circulation? Systemic circulation we talk about, because you open the duct and you perfuse the system, because system is closed, because it's a obstruction towards the left side of the heart. All right, this is important, coarctation of aorta. And then obviously you have also deal with them surgically. Critical pulmonary. So what is this? This is duct-dependent pulmonary circulation, or yes, this is pulmonary, not the systemic. And again, in this patient, normally you know how the critical pulmonary stenosis patient present. So they have critical pulmonary stenosis, and there is a shunt across the ASD, and then they start desaturating. They hang around saturation like 91. Okay? And then we came to know, and echo already showed there is a PS. Then we come to know, okay, this patient has, normally, with the passage of time, the saturation improves, and they don't need prostaglandin. But if they are misbehaving and they are hypoxic, saturation 70, 60, then might be you have to start them on prostaglandin. Normally, PS is a good, Allah na kare kisi ko ho koi congenital heart disease, but it's good to have PS as a part of congenital heart disease. ठीक है, ये I mean it's a good prognosis generally, जो right-sided PS है. Tetralogy of Fallot. This is again part of your FCPS training. This is the most common cyanotic congenital heart disease, and you have 4 components. What are those? Before that, right ventricle outflow tract obstruction and overriding. All right. And this is the most common cyanotic congenital heart disease. Also, it is fixable, or then also you need to know FCPS level पे कि how to break the spell of cyanotic spell. उसकी management वो you might get in the talks also. Epstein anomaly. This is again presentable. Tetralogy of Fallot little present late, but if they are critical tetralogy, then they present early. All right, and Epstein, they can present late also, but they can present early in the newborn, because we are discussing critical congenital heart disease in the newborn, so they can present early also. Epstein. And Epstein, they are difficult patients, but but you keep them in cyanotic congenital heart disease. I keep them on cyanotic congenital heart disease. And Epstein presenting in neonatal age has a poor prognosis. I have not seen survival for these patients. If they present in the newborn, very difficult to fix. We do a Starney's procedure in these patients in the operation theater. In developed countries, obviously there is a better survival, but in Pakistan, in newborn Epstein, they die. And again, sometime they might get with a prostaglandin benefit, but mostly this patient, if they are hypoxic, then you might give them a prostaglandin. Otherwise, you manage them medically and sent to the OR. Transposition of the great arteries, we talk about in detail already. So you need to know that they present with hypoxic, need atrial septostomy, and then you do arterial switch operation. This is arterial switch operation. This is one of the operation where you gauge your surgeon capabilities. So people say in America, if as an intensivist, if you want to gauge intensivist capabilities, single ventricle QP/QS circulation balance. This is an intensivist job. And transposition, they need to fix in the OR. They bring not much work for us in the ICU. So this is how, if you have a better single ventricle physiology in hypoplastic left heart syndrome, you have a better intensivist, you have a better nurses, you have a better team, because it is a teamwork. If you have a good result for transposition, that means your surgeons, they are better for that. So then there are centers, here obviously we are doing in Ittifaq, and still Karachi is not doing well. Here we have a best people who are fixing, alhamdulillah, and we are proud of that one. Because when I was resident in Aachen, we were sending transposition to India. So now we have a Dr. Asim, Dr. Faiz, Dr. Salman Shah, Dr. Jamal Abdul Nasser, the people we are fixing here, these patients. So this is a big achievement as a nation for us. And they have, very good result now. Because how you make result better? By doing more. And now there are a lot of technique, anesthesia is better, ICU is better, nursing is better now. So there is a better survival. But that text, the surgeon capabilities, how to fix these patients. This is the last slide, total pulmonary venous drainage. And again we talk about supracardiac, cardiac and infracardiac. Infracardiac, you need to remember it presents RDS, white out X-ray, fine granularity, and you are dealing with RDS, and your hypoxia is not unimaginable hypoxia. It's not improving. Patient is dying. You call for echo. Look for the veins. They have affected veins. All veins, they go down, and from down they come up from the diaphragm. With each breath, diaphragm is compressing pulmonary veins, and there is severe hypoxia. You cannot fix medically. These patients, they die in Pakistan, but in America, maybe 50% they survive. You put them on ECMO, then you take to the OR, you fix the veins, but they are very difficult patients. And you have to work very hard with these patients. This is X-ray. We talk about, initially we have shown you. You see, everyone talk about RDS, but this is not RDS. Maybe you have 2 patients in 1 year, but you have a patient which is giving you challenge. So what is the lesson here? Lesson here, believe me, it is available now. So my lesson here for you people, if you are dealing unusual, call echo. Call echo in the newborn. Call echo, believe me. And if you are dealing any patient abnormal newborn here and you suspect congenital heart disease, call me. I am expert in that field. Call me. Neonatal congenital heart disease. Patient might get help. Call echo and call me. Discuss with me. And we will discuss that what patient. And this is your learning. If you are not calling anyone, believe me, you cannot learn. Because your patient is going to die. Newborn presenting in congenital heart disease, they have a risk factor for dying. All right? This is a pathological specimen. Thank you very much. I put this. Thank you. So if you take one